excited to hear from you guys today. This is really an opportunity for all of us to put into practice some of the principles we've been talking about and hopefully be able to kind of look at it through a lens of a real world example that in some ways aligns hopefully with some of the issues and challenges that your organizations are facing and contemplating as you take on some of these issues with payers and with some of the initiatives that you have in your organization. Just as a reminder, you guys know who we are. Andy is not going to be joining us today, but both Samantha and myself are on the line today to hear from you and to, what did I do here? To talk a little bit about the case studies. So I'm going to just kind of a quick reminder, we've got today's session and then the next session that's happening on the 28th is really our final session of content. And we're going to talk about the use of risk adjustment and financial risk management and really focus on some of the core components that support risk management in the health center from a clinical perspective. So lots of emphasis in that session on how we use population health and care coordination and other clinical strategies to help manage risk. And continue to demonstrate the value of what we are providing to the payers that we're engaged in risk-based contracting with. And then the final session, which will happen on April 11th, is the group project. And Sam's going to talk us through those. And you all should have received an invitation to sign up for a quick touch base with the Starling team on kind of what your thinking is around that project. So if you haven't already, or if you're having trouble, because I think we might have, had to move some things around on the schedule. If you're having trouble finding time, email us. I know we have to work something out with one of the groups later this afternoon to try to find a different time, but we're happy to find a quick 30-minute time with your team that works for you. So with that, I think what I'm going to do is just sort of, so here's our quick agenda. We're going to go through the case study discussions, and hopefully you guys had an opportunity to gather as teams. We are looking forward to hearing from you guys on some of these scenarios. As I mentioned, Sam's going to talk through the final project, and then we'll just go through the homework questions really quick. So we did do some work to assign out the scenarios to folks, and if you remember, we did have a change. I think Redwood and Meaningful New York swapped places. So we have Northern Nevada Hopes, Lake County Health Department, and Meaningful New York initiatives working on scenario 1. We have Redwood Community Health Coalition, DCPCA, and Primary Care Inc. and Iowa Health Plus handling scenario 2. And then scenario 3 is Lakeview Memorial Hospital and Southwest Utah Community Health Center. So we'll have a chance to, kind of hear from everybody. So what we're going to do without further ado is we're going to just kind of review what our directions were for the case study. We asked that each group, be prepared to talk about the case study based on some of the experience that you guys have had within your own practices to help identify strategies and tools that were surfaced that might support the scenario in the case study. We know that you guys are likely to face scenarios very similar to these, and in many cases you probably already are. And, what we really want to do is hear about, from your perspective of looking at your case study, what you think, some of the competencies and infrastructure might be that a group contending with that particular case study would need to work through. So the way this was structured, we gave you guys a quick scenario, and then there were 4 questions that all 4 groups needed to think about through the lens of their particular case study. So we have our first scenario is your organization has been approached by a managed care organization to provide targeted case management for your highest risk patients. The MCO intends to provide a per member per month payment to support this enhanced case management. So with that said, let's look at the first question. And really what we want you guys to do is just kind of jump in, those of you that were sort of tasked with looking at this, and give us some insight. Identify which group you represent and kind of how you guys thought about each of the questions. So the first question is, how will the target patient population be defined? In this scenario, what do you consider to be the most important factors to determining high risk? So I'll turn it over to the groups now that were part of this question. Do we have anybody from the first group?
Todd, are you taking that one?
Pardon? So we're talking about, let's see here, anybody from Northern Nevada, Great Lake, or Meaningful New York? Anybody want to weigh in on the first question?
Todd, would you take the lead on this?
Yeah. I was on mute. I launched into it and then realized I was 15 seconds into an answer without while I was on mute there. So our population is our being the organization we are, the population that we serve, we'll be dealing with people with intellectual and developmental disabilities of all age groups who've been determined eligible for services through the New York State Office of Persons with Developmental Disabilities, New York State OPWDD. So this is the Medicaid developmentally disabled population in New York State. And then inside of that, we've identified some risk factors that we would use to determine high risk. So specifically, we have a set of categories. We look at the annual cost of care that's greater than 25% greater than the annual cost of care for DD services. Different than that, we would look at the same annual cost of care that's 25% greater than the average annual for healthcare services. We would see people with multiple medical diagnoses greater than equal to 4, people with multiple chronic conditions greater than equal to 4. We'll also look at some people who have a secondary psychiatric or behavioral diagnosis in addition to their developmentally disabled diagnosis. This makes them what we have known through our experience is a very high-risk group, just traditionally who need more one-to-one type supervision than can be received in a rehabilitation setting or in a resident setting. We'd also look at just like the general health care. We'd also look at, for our population, people who have multiple ED and hospitalizations per year over the past 3 years, defined as greater than equal to 3. And finally, we also take a look at the polypharmacy within the population, so that's greater than equal to 5 medications.
Yeah, that's a great list. And I think a lot of the things that you guys have identified are definitely variables that organizations that we're working with are looking at in terms of how to kind of risk stratify that population and really use really utilization data to help them tease out how to identify who would fall in these patient categories. I think I'll just stop there. That was really great thinking on your guys' part. Any of the other groups on this first question that how did you guys think about it, and maybe where did you kind of approach things differently based on the patient population, et cetera? So anyone from Northern Nevada or Lake County on the line? Okay. All right. Well, sounds like we're going to have a lot of discussion with the folks in New York this morning on this one. So you did talk a little bit about the data and information that you'll be using to risk stratify the population. Is there more that you guys want to add to that?
Yeah, there is. Okay, great. Yeah, there is. And I would say it's ironic that you're going to be hearing a lot from us because we are in New York being hidden by a nor'easter right now. So some of us are up to a foot of snow. So, yeah.
It's crazy weather. You guys are having crazy weather. Yeah.
So in terms of the data to stratify, we took a look at a number of things. So it includes the list we just talked about, but it also includes a little bit more. So taking a deeper dive into it, to also take a look at the claims reports that we have from individuals that we've been serving. So this is coming from our Department of Health and our Office of People with Developmental Disabilities. We take a look at the clinical medical classifications of people in the ICD-10. Then the next two are really linked for our population. So we take a look at their level on the IDD spectrum. That would be high functioning. So that would be behavioral, psychiatrically, emotionally focused people versus the lower functioning people, which require custodial care for adaptive independent living. And related to that, but not directly correlated because it also depends on their social supports, is the setting in which they live. So are they independent living? Are they, in what's called an independent residence alternative? Or are they living with a family if they have it? Are they in a supportive apartment or a supervised apartment, which are called supported or supervised IRAs? Or are they in an ICF-MR, which is the small, 6-bed or smaller institutions where traditionally in the last 20 years, the most complex individuals have lived. Then we also take a look at the age of the population because we've noticed within the IDD population, people are living longer and longer these days. So previously, the average age, life expectancy was much shorter than a neurotypical individual. But now people with IDD are living into their 60s, 70s. But when they do reach age, they have these additional conditions that come upon them in addition to their IDD. So we take a look at that. We take a look at the number of medical conditions that people have, the number of chronic conditions they have. As we mentioned before, we take a look at the number of medications people are using, the presence or absence of a behavioral or psychiatric diagnosis in addition to the developmentally disabled diagnosis. And finally, we take a look at the social determinants of health, including their social supports.
That's a fabulous list, and I think what's also really helpful in listening to you talk is, you guys are really aware of some of the contributing factors for your specific patient population that need to be built into that model. We've gone through exercises like this with groups that have been sitting down exactly to do this exercise in order to engage with plans on this issue. In fact, I spent all day yesterday on site with a client having this exact conversation with their very, very high risk, very challenging population. One of the big challenges in this area is this issue of where do you get this data from? Is it, and I think I'm kind of moving us now into the third question, but, are these data, available to you now in kind of your current systems? And if so, how are you accessing that? Are those in, standardized fields within your systems that make it possible for you to pull this data out of your electronic health records and other information systems? And if they aren't, what do you need to do to be able to create those structured fields so that that's possible? And then finally, are external cases or external data sets that need to be incorporated. And that may be the case for your population if there's a lot of transitional services and community services that might serve as triggers for assigning a patient within a certain risk category. So I'll just kind of leave it there and have you guys think it through with us.
Yeah, so I'll answer generally and then I'll get into the specifics. So generally, we have data, but it's scattered across different places being held by different stakeholders, and it's not organized in a specific, systematic, and consistent or universal way. So I'll explain. So what we have is, for instance, the state, the Department of Health, and the Office of People with Developmental Disabilities, they have the claims data, but they have not actually shared that claims data for our population with the providers yet. Although, when they're talking about the managed care transition and thinking about value-based payments, they haven't shared that data with us. So that would actually make it hard as when we're thinking about trying to, set a baseline measurement as we're measuring. You have to be able to do VBP. You have to have the baseline so you can determine if you did any improvements. Without that claims data, we really can't set the baseline. But they have it. Mercer has been working with them for a number of years to actually refine the data and share it with us, but it has not been shared yet. So that would have to be done. That claims data would finally have to be shared. Then there is, in addition to that, we would need the assessment data. So right now we have a really subpar assessment tool that's used when people enter the Medicaid system called the GDP2. However, that's being replaced, and it's actually being by a tool that's being normed and validated right now by what's called the Consolidated Assessment System, CAS, which is, people may be familiar with its sister tool, the UAS, the Uniform Assessment. And so they are norming and validating the CAS right now. But what we would need is that to be a state to finish norming and validating that, and then to administer the CAS to all the people that we're serving. That way we have really those baseline scores on exactly on their across all the different domains. So whether it's on their psychosocial functioning, whether it's on their abilities or lack thereof, and also on their looking into the physical and acute care needs. So we need them to go ahead and administer the CAS and then share that data with us. And then also, I think we do have an EHR. So we do have an EHR. However, up to the present, we really there's not been a huge focus on the coordination between the healthcare side and the long-term care side. So there would have to be a greater emphasis on the healthcare side, specifically in the areas we're speaking of hospitalizations and ER visits. We'd have to start taking a closer look at that and coordinating the data and actually apply it into use, so that we can start once again having a pre-measure of how many hospitalizations these people are having, and can we do the structured interventions to avoid. Clearly, the key term would be the preventable or avoidable hospitalizations rather than just the hospitalizations in general. So, so within, I think, a lot of things, I think we have actually lots of data, but then it's keying in within that wealth of data, basically following what would be, our research questions and keying in on what are the important pieces of data that we want to dive down, take a deeper dive into, and track and use as the basis of our VBP measures. So really, it's defining the measures out of those data sets that we have and start using and tracking them. And that's really work that needs to be done that has not been done yet.
Yeah, I think that's really, I think that's great. Do folks have questions for them before we move on to the next one, or anybody else from the other groups maybe that haven't had a chance to talk yet? I'm not sure if you guys are on the line now and want to pipe in with any of the perspective you had from working on this. This is again for Northern Nevada or Lake County. Okay, well, let's take it home, New York. So what tools, resources, and infrastructure will your organization need to put in place or use to target interventions for the patient population? And are those available now, or would you guys need to be developing them as you're building out these strategies?
So it builds on the answer that we just said from the past one. So we would really need to have these tools and data sets, implemented. So we would need access to the claims data from the Department of Health. We would need the CAS to be administered and have access to the assessments on the individuals. So we have the EHR. We would just need to expand the use of it to more on the healthcare side, and we'd also, but thinking bigger picture than that, the structures also have to be finalized between, let's say, within our state right now. those set of relationships are getting formalized between the different organizations, between the different entities. So we're having, what are really building are these regional collaboratives or regional networks of what are becoming the care management or care coordination entities are forming. And so that these create the relationships between these entities and the MCOs. In some instance, it's actually the MCO or the group of providers that run the MCO actually is also becoming a second entity, which is the care coordination entity. Those sets of relationships need to be finalized in this space for ours, which really follows what New York State has done in other areas. So in the general Medicaid space, those relationships have all been taking place, and the hospitals have been forming collaboratives with all of the behavioral health providers and the acute care providers and the primary care clinics and the FQHCs. We need to do the same thing in our space and to formalize those relationships. And as we do that, it will change our staffing structure too. So we have to, it'll change our thinking. Because like I said, we've been so focused on the long-term care side. We'll have to be having additional emphasis to keep our eye on avoidable and preventable hospitalizations, which under the fee-for-service system, there was just no incentive to avoid preventable hospitalizations. We have to put those staff in place, the licensed clinical social workers, the MSWs, the nursing practitioner. So it actually will change our staffing structure too as we change our workflow and as we change the tools and data we need. So it'll really change the model. We'll go from people who have been coordinating care, who have been, maybe just out of high school level people, sometimes college, but to a much higher level of credential and a much more sophisticated way of thinking about the coordination of care.
Yeah, I think that's a really important point. And I think that sometimes when we start thinking about the PMPM structure, it's really important to think about that exact issue that you just raised, which is how does your infrastructure need to change in order to really support the new model? And how do we make sure that the payment methodology that's being provided through the PMPM is going to be sufficient to do that? And so invariably groups like yours will look at new care coordinators as kind of the driver in terms of where some of the costs are. But as you well know, and you just indicated it by talking about how many parts of the system this model needs to interact with, there are other kinds of costs and resources that need to be directed to make sure that those care teams and those care managers are successful. So we really encourage you to kind of think about, what are some of the other costs that get impacted, although obviously care coordination staff is key. The other thing you hit on that I think is really important is the point that you made that in your market, working with these patients is not necessarily something that you guys are doing in isolation, that there are, particularly with other provider service types like hospitals and behavioral health, as well as the payers themselves may have some of that infrastructure. And it's really important in those scenarios to understand what, and clearly delineate roles and responsibilities for all those various entities. One, it helps you have a better sense of what your workflows need to be. It helps you understand if your payment methodology, in fact, is sustainable for the things that you're responsible for. It's also really important that those patient flows and workflows are clear to the patients themselves, because we often see confusion on the part of the patient about, kind of who is their care team, who is supporting them, and really making sure that that's clearly articulated not only among the project partners, but also with the patients themselves. But I think it is, and it's really funny because anytime we sit down to have this conversation with a group that's going through this kind of an exercise, they want us at Starling to be able to kind of tell them, well, what's the magic formula for care team configuration and high-risk care coordination? And truly that's going to vary so much depending on who your patients are, what kind of natural partnerships you already have in place, what kinds of emerging needs you're expecting to see. And then we all work in provider settings, so we know sometimes we can lose one good staff person who was kind of the glue to the whole process, and we have to like rethink our infrastructure altogether. So, we're going to be talking a little bit about what some of those infrastructure pieces are, but I think what I really appreciate about what you guys have shared is the fact that you're looking really comprehensively at how to put this model, how this theoretical, for the case study model would be put together, and understanding that there's some things that are quite dynamic about it. And if there was a one size, fits all cookie cutter special sauce recipe, we'd all be millionaires for having bottled it. So, I really appreciate the perspective you guys brought, and I think it's particularly interesting given kind of the complexity of your patient population. Anybody else have questions for the group before we move on to the next case study? Okay. Well, again, thanks again, guys. I thought that was very, very thorough, and I think that Samantha and I both feel like you guys could probably teach a lot of the content that we're providing content on, because your perspective was so good. Okay. The next scenario is a model where the organization is participating in a regional care organization. This is a model similar to an ACO to better coordinate care transitions for patients who've been hospitalized for congestive heart failure. So in this scenario, we identified, a region and a set of patients that would be the target population. The RCO has developed a payment model that provides payment for particular performance activities, and also distributes shared savings back to provider organizations participating in the RCO. The same questions as before, but I'm going to turn this over to Redwood Community Health Coalition, DCPCA, and Iowa Health Plus to kind of help us think through some of these questions. So let's start with the, actually in your scenario, number one is pretty, the first part of number one is pretty easy because it's been, for the most part, defined for you. But let me turn it over to the three organizations. How will the target population be defined? And in this scenario, what do you consider to be the most important factors to determining high risk?
Hey there, this is Megan from the Iowa Primary Care Association. So knowing that our target population is folks who have been hospitalized for this specific medical condition, the risk factors that we talked about were previous hospitalizations, whether the patient has an existing diagnosis of heart disease of any type, hypertension control rate, family history, if there's any way to track that in, say, the EHR system, or that really might be an opportunity for providers to input their own discretion. We talked about medication compliance, if they have a history of heart disease, if they are on some sort of heart medication, how often they're complying with that. We talked about smoking. That's often a risk factor for heart disease. And then at the PCA, obviously, we focus quite a bit on social determinants of health. So we talked about, does the person who has been hospitalized, do they have social supports? Do they have someone at home that can help them stay in compliance with their medications? Things like that. So social determinants was high on our list of risk factors.
That's great.
Hi, this is Teresa at RCHC. Our list looks very similar to that. We had a couple of additional, those actually admitted with a primary reason for exacerbation of CHF or new onset of CHF, lack of insurance, just impacting access to medications potentially, advanced age. And then we had similar social determinants factors.
That's great. No, those are really good additions. DCPCA?
Hi, this is Tricia from DCPCA. I don't really have a whole lot to add. I think The main issues really for us in this scenario are what access do we have to the data that we need in a timely sort of way. So I think generally speaking, we have access to all of this data. It's about the timing. And, so we would love to hear, as we go through the questions, people's strategies for, in particular, the sort of discharge summaries in a timely manner. We are exactly at that place, actually, with our health centers in terms of our Medicaid office about to launch a health homes program for, not specifically on this disease, but just in general, high utilizers with multiple chronic conditions, of which this will definitely be present. And one of the most challenging things for the health centers is in that transition relationship with hospitals, because we are an urban center with multiple hospitals. I mean, there are some that are more utilized than others, but we have, they would need, each center would need relationships with a number of different hospitals, and we're trying to streamline that as a network in some way. So I'm really interested in hearing from Iowa, knowing that you guys have a network. What are the tools and strategies, and how did you negotiate those relationships as a network with hospitals?
Yeah, that issue is one that is, it is a huge challenge, because many primary care and community mental health and organizations have individual relationships that they either have that have been, accepted over the years, or sometimes you just have a hospital partner or a health system partner that's just really challenging to work with, or sometimes doesn't want to come to the table when there's one of their other hospital competitors in the room. So those are challenges that I think most networks have in trying to, particularly when they operate in an area where there's like a multiplicity of hospital health system partners.
Yeah, and I read one article that said that like the risk for readmission increases every day beyond discharge, that the discharge summary is not completed and transmitted somewhere. So it's just like a ticking clock that, each extra day it takes to get that in the hands of the right people.
Right. And I think that, I think there's a couple of things that we've seen. I mean, sometimes the network itself and the health center itself can be almost, the way it was described this week with me in the meeting I was in yesterday, where there's two hospitals that don't like to work together, but the organization in the middle that's trying to do all this coordination essentially functions like Switzerland between the two hospitals, and they've been able to kind of carve out a way to do that. No, but you're absolutely right, and gaining access to those types of data that, the admit, transmit, and discharge data, so that you even know that your patient has been in the hospital or had an interaction with the ED is critical. So let's talk about that a little bit in terms of the data and information that we would need. I mean, obviously we need some kind of, it sounds like what you're saying is that discharge data is different. Are there other data and information that the three groups that are responding to this one thought would be important for this group?
I think we need payer data. If this is, we would need to know which patients are assigned to us, what members we're managing, given that this is or an RCO. So we need to know if we're, what that population is. And then we need certainly EHR data. Just once we get the hospital notification of discharge, what do we have internally as far as demographics, clinical information, and other social determinants already on that patient in our own systems. And then other social determinants of data, if we can get it from our county or housing organizations or whomever else we have in our network.
Mm-hmm. I think the other area that came up with you guys is this issue of medication reconciliation and pharma, right? Because it's such a critical piece of the transition.
Absolutely.
For this. Certainly the you're hoping that that's in your health record, but if they're out seeing specialists and those and prescriptions are changing, that there's that that coordination's going on as well.
Yeah, that was listed as another major readmission risk factor, is the sort of numbers of medications and poor medication reconciliation.
Right. Other input on the second question around data and information? That's a great one. This RCO would be lucky to have all of you guys with as much as you've thought about this so far.
Nothing to add.
Okay. So based on kind of how we've thought about the patient population and how to risk stratify them, if you were just to look at the systems that you have now, what data and information do you have now? Where is it? I guess we talked about this a little bit, claims data and the ER data, the EHR data. If you don't have it, or if you think your organization would struggle to try to integrate that, what would you need to be putting in place to gain access to that, and what would be some of the structure around using that data?
So DCPCA has been using a platform called VLC that can synthesize claims and medical records data, and can get hospital alerts via the hospital HIE. But the main thing is, right now, our health centers get hospital alerts, but it's sort of limited to the primary care physician getting some sort of email notification of a hospital, an ER or hospital admission or discharge. And it's just not functional in terms of the way their teams work for that message to be going that way. So I think we're sort of on the cusp of being able to do a lot, because we have a platform that will synthesize a lot of different data sources, including claims, and does health risk assessments, et cetera. But it's sort of, it's sort of streamlining all of that and then beginning to really train centers in what that means for how they utilize the information from a workflow standpoint, et cetera. It's sort of like it's going to be really worse before it's better, and that's kind of where we're at right now.
That's interesting. How do those alerts come over, Tricia, from the hospital?
So right now they come, my understanding is they come only to a designated PCP within the health center. So, care teams don't have access to that information, and it's not centralized in some platform that everybody can go see or be aware of. In Healthy C, you can choose who's going to get what and in what manner, and Healthy C has a care management platform that will sort of alert as soon as somebody logs on to the system, if it's somebody in their bucket in some way, that they'll be alerted, and it will be different prompts for the care management team in a way that just isn't functional right now. And as the interim CEO at DCPCA says, it's like when care stops when information stops. So any place where information lands and does not, move from, then, that's kind of where things start to fall apart in terms of patient care.
No, it's a good point. And I think from a workflow perspective, we've seen some groups look at trying to create a system where that information does come in centrally, rather than at the individual PCP level. And that allows, really for that to be somebody's job, is to kind of manage what those alerts are and how they're coming in, and help support the care teams at the various health center sites or the care delivery sites to be able to use that data in an actionable way. Because we all know that, somebody can be out for a day and it could throw everything off. I was just at it, again, I keep coming back to the meeting I was at yesterday, but literally we were meeting with a group yesterday who there's one woman who probably 50% of her job is going through emails that the doctors get exactly to this point and putting them in the HR. And that is her exact 50% of her job. And after I pulled the fork out of my eye, and thought about what that meant from a workflow perspective, I was like, there has to be a way, even if you don't have perfect information exchange with the hospitals, to find a way to make this more efficient. So I think
the new system should be. I'm interested from other groups to know, integrating is it ever possible to integrate sort of a care management platform with clinical data? So right now we have ECW for the medical record inputting, and that's what all the providers use. That does not have a very functional care management component that people love. It's not, my understanding is that EMRs were sort of billing focused versus care management focused. But we're still dealing with the hesitation of you may need a separate system for your care management that can integrate EMR data, but, it's not going to be done from the EMR in some mythical way that people want the whole thing to work.
Right. We can speak a little bit about. Sorry, go ahead.
No, I was just going to say. I was going to ask. Yeah.
Yeah. So this is Teresa at Redwood. So most of our health centers are on ECW. Some are on NextGen. Just on the care management piece. Yeah, I think some of these EMRs were really built as practice management systems. And ECW does not really have a great way of managing a cohort of patients, right? There's not, right. So we're kind of piloting a couple of different strategies there, where we've kind of got a best in class template, a care management template. At the very minimal would be a tool for somebody doing, a nurse or a case manager doing their work, to at least be able to document those standard elements in a way that the rest of the care team within the tool that they're working in can see it. Yeah, it won't necessarily, give them a list of patients. Then we're doing more in depth, actually kind of looking at the ECW care management platform that's available, and seeing how that can work, because that is, you do have the ability to designate a care team on that one. So we'll let you know how that goes. We're doing kind of both of those strategies right now. Just on the admit, discharge, transfer, feed, and continuity of care documents, we have we build a private HIE so that information does come directly into the EMR. So we're testing that right now with St. Joseph Health System. They're receiving our demographic file and can now identify if it's a patient that belongs to a health center. But we're trying to deliver that, similar to you guys at DC, into the EMR, into the specific Jelly Bean, and we're trying to get those assignments set up so that it can go to more than just the PCP to offer, an opportunity for covering when they're out. So we know we have the EMR data, but we don't have it aggregated. So assuming in this scenario that that the case management is happening at the health centers and we're doing some central coordination of it, we know we need to build a way of aggregating what's going on, and really being able to monitor a transition of care program centrally and have an infrastructure in place to know that the work's being completed.
So one issue that we're confronting and is that nothing is ideally suited, but we are often in discussions with health centers that it's like they're comparing what you're proposing to an idealized system that doesn't really exist. Do you know what I mean?
Exactly.
It's an unfair comparison. Like, yes, it doesn't do X, Y, Z, but there's no thing that does that, or this one has all those other problems. So I have to keep reminding them, like, we have to compare reality, not what we wish in all the best world it would be. We do have a health center that has gone pretty far down the path on trying to work with the ECW care management platform, if that's of interest to you at all, in terms of, as you embark on doing that work, you may have some insight. So let me know if that's something. You can just shoot me an email if you want me to connect you to them.
Terrific. Thanks.
Iowa, how about you guys? What did you guys think about with regard to this particular question around what you have and what kind of workflow or infrastructure might you need to put into place?
So one of the things that was top of mind for us is the fact that our network currently doesn't have any kind of population management solution. That's been a top priority for us for quite a while, and we've got an active work group that's been vetting different solutions. So some of the main challenges we would have in implementing a risk stratification strategy like this is that, number one, we don't have readily available claims information. So it would be a lift to access that data. And then once we have that data, we don't have a very usable solution to make any of it meaningful. So that would kind of be the first step for us. We do have access to some clinical information through EHR systems. Another one of our big challenges, which sounds like it's similar to some of the other folks on the phone, we've got a number of different EHRs represented in our network. So our CHCs have different EHRs between them. And we have run into some challenges in making all of those things talk to each other and make the information flow to the network in some sort of aligned or standardized way. So that information is pretty fragmented so far. Then we also talked about the availability of social determinants data. So 2 of our health centers right now are using the Prepare tool to gather social determinants data. I think having some good success with it, and so we have made it a priority to work on rolling that out among more of our health centers, but that is something that would still need to be done if we were to do something like this. And then there too, formalizing the data analytics and data tracking processes necessary to make any of that meaningful.
From the ADT perspective, all of our health centers are in different places in terms of their relationships and data flows with their hospitals. Interestingly, it tends to be our smaller areas, our more rural areas that have more hospitals to work with versus the urban areas that are some of the larger network systems. So kind of the opposite of what I think intuitively you might think in that regard. And then, but as an ACO, we do have access to the ADT system that the state has set up to the health information network. So we are receiving information from the hospitals that have voluntarily chosen to participate. We get that centralized at the network, and then we send that back out to the health centers. We're in kind of a pilot phase at this point to ensure that the information is helpful and sent in a meaningful way to them. It is an electronic automatic process that we've developed. It's not feeding it into an analytics type of tool or into the EMR directly, but that is a goal that we have, and one of the parameters that we are thinking about as we continue to vet various analytic tools that we'll be purchasing by the end of the year for network usage. So the health centers have some of their own tools, and so we can use them. They're just not aggregated up to the network level.
Yeah, that makes sense. I think that makes total sense, and I think that's pretty typical. Where we see that, particularly in a network like yours, Iowa, where you guys are working statewide and the relationships are local, and often some of the infrastructure for, in your case, the health centers is probably built in to some degree with, those individual relationships. So it does make it hard to aggregate it across the network. So I definitely can appreciate that.
As it relates to the hospitals, there was a question about that. I just wanted to mention, too, that so we don't directly manage those relationships. It is incumbent upon our health centers, and some are very positive and they have access to their EMR systems, and others are a little bit more adversarial. But we do use like the alert system that the state has as leverage to enter into conversations with the larger systems. So the network does influence some of those relationships as we think about how to do apply some of these statewide solutions.
Right. Okay, so let's move on to the last question, and then we'll move on to the last group. But for the three groups on the line, we started to talk a little bit about this as it relates to some of the conversation we were just having, but what are some other tools, resources, and infrastructure that you would need to put in place to be able to really target these patient populations? And is this stuff that's fair, or is it stuff that would sort of be in an ideal state if you had to develop it?
For DCPC, I'm sorry. Go ahead.
I'll start, and then I'll hand it over to you. In Iowa, we talked about how on a network level at the PCA, we've got, we think, the staffing infrastructure in place that would be necessary to implement a lot of this. So we've got the right people. The question would be their capacity, if they could take on like the analytics capacity necessary to do this. We've got a PI department that could work with the centers to implement workflows. So capacity would be the big question on the network level. And then going into the centers, we know their first question would be whether or not they're care coordinators, whether they've got the right staffing level of care coordinators, and whether those folks have the capacity to pull this off. So staffing would be a major infrastructure question for us. We'd also want to know if we should look at partnerships to help implement this, so partnering with home health service agencies, whether we need to partner with anybody else to get more analytics capacities, things like that.
Yeah, those partnerships can sometimes be really important because it helps you to leverage existing infrastructure for sure. Did you have some additional thoughts?
Well, definitely the staffing piece. And I'm curious if anyone else on the call, if your state or locality, whatever, has implemented any of the health home models via what was created via the ACA, opportunities to do health home models, because the staffing that our healthcare finance is requiring for centers to participate in a health homes kind of bonus is really difficult. When we look at the attribution for all of our health centers in that health homes model, they collectively would have to hire, I want to say it's nurses in the hundreds, like, maybe 150 nurses or something like that, which in our market is incredibly difficult to achieve. And I don't know how much what our healthcare finance is doing relative to staffing in that model is prescribed by the rules of the model, and how much is their view of exactly what the staffing pattern needs to be. It feels rigid and expensive and difficult. And go ahead.
Oh, I have a question on that. This is Sue Wilkie from Family Healthcare. And when you're talking about health home models, can you tell me what you're specifically talking about? Is that the NCQA patient-centered medical home model, or is it another type of health home?
Yeah, it's another type of health home. It's specifically designed around patients with high utilizer patients, high priority with multiple chronic illnesses. They did one around severe and persistent mental illness a little while ago that didn't fully engage health centers. Now they're rolling out another one that is specific to Medicaid patients with multiple chronic illnesses. And in the end, because of the staffing they're requiring, it's really difficult to see how the financial model works out, you know.
Hi, this is Teresa in California at Redwood. So, yeah, I think exactly. It's difficult to know how it's going to work out. Plus, you know, before there's money to pay for it, how can you even quantify the cost? It's the conundrum that we've been in. Yeah. So we have, we're in 4 counties in Northern California, and luckily we have the same managed Medi-Cal company in all of them. So they have been running an intensive outpatient care management program. It's a very small group of patients, but they've been essentially providing a list to pilot health centers to participate and do care management for these folks. And, you know, they're all tiered, and they have particular, you know, they've been vetted by the health plan and given to the health center, and there's reimbursement for care management. So it's been a sort of a plan, you know, ours is 2703. That's our health home in California. It's kind of been a 2703 light program. So we're working with our health centers on some of the components of care management. Given that the 2703 has kept, you know, moving back and back and back, but I think our health plan has been able to help us advocate with the state. We quantified what we think the cost is going to be based on the given model of, you know, care management staff, because it's very prescribed who you have to have in place and what their roles are. And so it's just, you got to push back hard and, you know, try to, if you can pilot it on a small scale and understand what your potential costs are and your FTE costs are, you know, and get your state PCA involved in the conversation. That's what we've tried to do here.
We are the state PCA.
Oh, you guys are.
And we have been trying and pushing back and saying, you know, this becomes unworkable unless you're a very high-performing, you know, in terms of enrollment and keeping the touches going and all of that. It's just pretty tough.
Yeah.
Yeah,
absolutely.
Thank you. That's helpful.
I would just add, this is Gilbert Lewis from Meaningful, New York. In New York, the current system for supporting people with IDD has been to have an independent case manager, sometimes embedded at the agency level. And we're spending about $300 million on case management, and it being done in a way that is somewhat fragmented. So the idea is to go to a household model that the state is using for a number of other populations, and using this funds, this $300 million that we're currently spending to create this new household model. But our experience on the MH side has been one that has not been very positive. Therefore, there is a reluctance on the part of organizations to participate or to promote the idea of moving from our current system to the health home system.
Yeah. That's helpful. Are we leaderless for a moment there?
Sorry, I was talking and I was on mute, so sorry about that. What I was saying, and it was, you know, highly informed and interesting, was, not really, but what I was saying was one of the things, you know, we've done a lot of talking, particularly around this scenario, well, with both scenarios, but with regard to the scenario around the type of data for the risk stratification and the clinical and utilization outcome measures. And one thing to keep in mind with this particular scenario is because it's looking at a shared savings model, part of what we would need to be looking at is our performance relative to our benchmarking, the benchmark data, because that's what's going to help us understand how much shared savings we would be potentially eligible for under this model if our outcomes were hitting the targets or not hitting the targets that they needed to hit in order to draw down those shared savings. So another part of, and this is kind of a combination conversation about, kind of understanding the risk, the risk scoring and the risk opportunities with our patients, but also understanding what that means in the kind of year-over-year baselining and our ability to pull down shared savings, because it's a different kind of payment model. We want to really understand, as part of our data collection and data analysis, where we're likely to stand relative to our ability to pull down that gain sharing. So it's just another competency that goes into place because the risk of your patient population may determine the risk factors of your population. May determine kind of what the models are for your ability to pull down shared savings, and we would want to make sure that any expectations around gain sharing were properly risk adjusted. So I just put that out there because this is a little bit of a different payment model than the PMPM we just talked about, and a lot of the health home and 2703 programs we were just talking about typically are structured in some form of PMPM, but this is a little different because of the model of gain sharing with the payer. So
this is Cassandra Beardsley from Wilderness, and we're in a Medicaid ACO with the state of Minnesota, and one of our really big aha moments was the cost of drugs, because that is included in our shared savings calculation and really had an impact. Our first year we were astounded. We knew drugs cost a lot, but that would be really key to understand what the prescribing patterns and costs were, and if there was any opportunity to make improvements on that or not.
That's a great suggestion. And I think, we did talk a little bit about medication management with respect to this population. The CHF population is, there's a lot of, activity that could go around that. And I think that there are really important lessons to learn in those scenarios. And that's great, Cassandra. Thanks for bringing that up.
Yeah, we have a great generic utilization rate. I think it was 91%, but we see the cost, just standard maintenance, generic prescriptions even going up when we look at those claim files. About every 3 to 5 months, the billed cost goes up. So there's very little impact that can be done other than to make sure that, prescribing is appropriate and and whatnot. But that's a very challenging aspect to handle.
Right. That's a great point.
We're having conversations with the state about that as well.
Yeah, I would imagine it's a huge issue. So the last scenario is around a regional collaborative to support social determinants of health. And we wanted to put this scenario in here because there have been quite a few state innovation model and CMS Innovation Center opportunities that we've seen safety net groups get involved in over the last 2 years. We anticipate, potentially seeing more of that in the coming years around working kind of in this cross-functional way with primary care, behavioral health, and, working to coordinate with community service providers who are really trying to get at some of the cost and quality outcomes tied with, referral management and referral coordination to community-based services to address social determinants of health. So in this scenario, we asked the two groups, Lakeview and Southwest Utah, to think about, if your organization was participating in this kind of regional health care provider organization and community-based organization collaborative, really working to link patients with community resources, behavioral health services, healthcare providers to better meet their comprehensive needs of the patients, including social determinants of health. Some of that funding provided by the state to support community health navigators to link those patients to various parts of the system. So essentially having almost, this community navigator taking on, to some degree, what looks a little bit like a care coordination role, but really looking more broadly at kind of the totality of health and social services coordination that might be necessary for those patient populations. So a little bit of a different spin on it, but nonetheless, models that we know that a lot of safety net organizations are contemplating or participating in. So I think I'll turn it over to the two groups to sort of say, when you guys were thinking about this, or sort of ask the question, how would the target patient population be defined, and what would you consider to be some of the high-risk factors that you would need to take into account?
This is Sue from Southwest, or Family Healthcare, and we're just kind of at the beginning of this process. Our state provided a small amount of seed money for us to hire a part-time nurse to do beginning case management. And interestingly, the state department that's funding it is the Pap smear mammogram group. So the reporting and the deliverables I need to give back to them really surround HPV vaccination and Pap smears, but not with the chronic diseases that I actually need to track for my highest risk patients. So just a little bit of an odd connection there. And the challenge that we see that we're facing with that is to figure out how to hire the right person who has the skills that are both clinical with a registered nurse and personal and problem solving plus role building. And we're finding with our PCA group that other organizations that are a little bit ahead of us in that are really struggling with hiring the perfect person, because you only get one that's part-time. You have to have maximum deliverables. And where do we get training money and support to really have that take off and get lots of patients enrolled and do a beautiful job with them, that all things would be reimbursed. So that's a little bit of a challenge for us right now with that. So if we're looking at question 1 on how we would target the population, so mine has to be targeted around Pap smears and mammograms, but really what I'm trying to figure out is how to make it work for diabetes and our hospital discharges and those high-risk patients. And in determining high risk, the challenge of what's high risk that doesn't overload the system with a brand new, who will soon be a brand new person to the employee, to the organization, and new to case management. And all of our patients are really pretty high risk because we are a rural FQHC and high uninsurance group and high rate of people below 100% of poverty. So then it's how do you make high risk so specific that they only get a number of patients that they can actually manage in the system. We're using Bridge IT as we go to question 3. Bridge IT to help pull our data out of eClinicalWorks. ECW is less reliable for its data retrieval for HEDIS measures and other measures that we put in there, so we have to blend the two of those. But we don't get data from claims reports or health risk assessments or those kinds of things. It was brought up earlier by the great discussion that I've been listening to on payers. So when our payers come in and do the regular audits on our charts, Medicare or Medicare Advantage plans, Medicaid or Medicaid HMO groups, or someone like Optum coming in, and each of them tell us what we're not doing well and how to do it well without the resources. But then when they say they have case managers working in their system, we don't really have a way to blend with them on who's doing what and outreaching to the patient so that we can have a targeted way to actually reduce risk for the patient. And then on our number 4, in our system, we have a 0.5 care coordinator who is a medical assistant, and a 0.25 community health worker type who has been assigned only to do Medicaid application completion forms because she's already overloaded with just that. So we're really not even able to get into the discussion you've had before on what's real care coordination and care management. Regarding what Redwood talked about before, because I know you're using eClinicalWorks, we have purchased the CCM module for eClinicalWorks and also the PCMH analytics modules. And they're not as easy to actually use as they say they are, but we're getting there and trying to develop so that we can actually bill for care management services for Medicare patients in the 20 minutes a month, so that then if we bring in enough money, we can actually expand those services to the population that needs it as well, which is our uninsured. So you discussed also earlier hospital discharge care transition processes, how to get that data. And our current program is to get the data via a fax from the hospital. That comes into our system electronically, and then it's reassigned and put in the jelly bean of the particular team. When that works beautifully, that's great. But my concern is always, we don't know what we don't know until we know it. So how do I know that I'm getting 100% of the hospital discharges that belong to us? And how do I know that we're responding to 100% of those that we get? And that's been a real concern. And I wrote down the quote that someone had said earlier, care stops when information stops. And that's what I feel terrible anxiety about all the time when it comes to care management resources for a high-risk group. So just the other thing I wanted to add is I was on a call this week to a group that our PCA is working with on care management that received some seed money earlier than we did. And their seed money came out of the state diabetes department. And so they hired an RN part-time, 0.5, and have had her for 3 months before in January they were able to enroll 10 patients in the Medicare CCM program. In February, 27 patients, and in March they're hoping to target 45 patients with aggressive training, aggressive work, and that tells you how difficult it is and how slow it is to start those kinds of programs to really even get enough data to see who's joining and how do we use the resources. And they haven't yet even received, because they're new with it, January, so they haven't even received any payment yet to know how well they're being reimbursed. So those are just some of the things that, I'm concerned about and thinking about, but wrote serious notes on the things that you all were talking about in trying to see in a regional collaborative or looking at how to connect with our hospitals or our insurers. What we're trying to do, we're all wanting to do the same thing, but we're really, really not collaborating across the different agencies so that I'm not either redoing or undoing or not doing the things that we're all hoping toward. So those are just my comments for today.
Yeah, and I think it's particularly challenging with this scenario because I think as challenging as it is to work with other medical service providers and hospitals, trying to translate some of this stuff in terms of the data tracking and the patient tracking, when you kind of cross over and work with organizations like, domestic violence or housing or food insecurity, it's like speaking two different languages. And I think, having the right person in the middle who's kind of leveraging the relationship between, in your case, the FQHC and the community service providers. It's a, to your earlier point, you gotta kind of have to find a little special sauce there with somebody who's comfortable kind of operating in both those worlds and trying to really build those relationships and identify what information they might need when thinking about their patient population that would potentially trigger things, referrals or coordination with service providers, or the inverse being true as well. Like, community service provider has a patient that has medical. Like, how do you coordinate that? And I think that's a challenge for sure. But I think it's I think you guys are just continuously highlighting some of the key issues that that we think need to be hit on. And I think that, this idea of getting the right staff in place, finding efficient models of data sharing, figuring out how you use your data systems that you have in place that maybe aren't perfect but have some functionality to really support the care teams. I mean, these are really the challenges that these types of activities on the risk stratification and risk management side of things really force us to contemplate. And I think you guys are hitting a lot of the same issues, and I really just encourage the conversation, to keep happening where you're sharing this back with each other. I do want to leave Sam a little time to talk about the final project. So Lakeview Memorial, are you guys on? Do you want to talk at all about kind of how you approached this case study?
Sure. This is Cassandra, and I'm with Lakeview, and Lakeview is part of a larger collaborative called Wilderness Health, which is 9 hospitals in northeastern Minnesota. Some of the hospitals employ or engage the FQHCs or the clinics in their communities, and others struggle to get those FQHCs on board. 7 of the hospitals are critical access hospitals, and then 2 of them are larger. One has 87 beds, and the other has 287 beds, I think. So it's a blended model, and we've actually been working on, how do we work with our other partners? We do have this Medicaid ACO with the state of Minnesota, and have recognized for some time that, you need to understand your patients' personal situations. So what we did was we take a look, trying to use EHR data, and that's really a challenge. Everyone's got different systems. I was really intrigued to hear that many of you on the phone are using ECW on the clinic side, and we've actually, for 2 years now, been trying to work with the CCMR module that we purchased from ECW, and happy to have other conversations about how that's been working or not working for us. We do get claims information from the state on our attributed Medicaid population, so that would be the group that we would be looking at here. And what we're looking, we're stratifying, looking at those patients who have 6 or more ER visits over the course of a year, or more than $50,000 in claims, or if they have 4 unique providers and no indication of a primary care home within the previous year. Also taking a look at diabetic patients who have one or more chronic conditions, and or sometimes people will meet all of these categories, but we're also taking a look at risk stratifying those patients with 4 or more weeks on an opioid prescription. So those are the categories that we started taking a look at and identifying. Our challenge around the social determinants of health is that data is not consistently captured or requested from the patients. We might get some information through claims. Some providers might request that information, but it doesn't seem to be done consistently, and some of those fields aren't even able to be tracked. When we went through and looked at the questionnaire, we found that we may need to add data fields into our systems And we would definitely need to add consistent processes to request and track that information, whether it's at time of registration, if it's at the bed, if they're in the hospital. On the primary care side, the care teams would need to request that information. And what we have found as we're trying to establish some consistent care coordination processes is that there's a lot of education that needs to be done with staff. When we've identified these patients through claims, we get some resistance from the established care coordinators at clinics saying, you know, why have you identified these patients? What do you want me to do with them? Or, you know, oh, I see that they have a primary care appointment. I don't need to do anything further. So trying to educate staff on how we're trying to prospectively look at population health rather than just treating patients when they're coming in for care. Seeing that big picture about how they can interact with folks differently. We don't have a state HIE in Minnesota. They went away from that. So there are multiple HIEs within the state. That's a challenge when you're trying to exchange information. We've been looking at getting ADTs just from our own member hospitals, and that has been somewhat burdensome. So we found that we needed to add a project manager on our end around the IT side just to work with our vendor and make sure that we resource that appropriately. Other challenges around just finding the right care coordination model and resources. It's, you know, the payment for that is little, if any. And so it's a challenge to get providers to commit to hiring care coordinators and not having them be distracted from things like rooming patients and following up on other things. Just, you know, the reimbursement isn't there, and shared savings, if and when they come, are after the fact. So you have to invest money up front, and you may or may not get that in the long run. So getting buy-in is really a challenge.
No, I think those are all good points, and I think it's important to think about, you know, how we think kind of about the evolution of this work too. You know, one of the things we tell folks always is, you know, don't necessarily think you need to sit down and go through the paces of these complex care management programs for every single patient. But I think, you know, sort of testing it out, trying to figure out how to use these systems, how to figure out the right staffing models, doing these things in incremental stepwise approaches is really going to ultimately serve you better. But I just really want to commend everybody. I think there's been great sharing of experiences. I think you guys have, essentially punctuated the points that we've been trying to make over the last several weeks with regard to a lot of this content. And we really thank you for your time in thinking through what's going on with your particular practice and how it fits into the case study example. And we just really want to encourage you. I know that, you know, part of why we interject these case studies in at about this point in the virtual learning collaborative sessions is to really provide another opportunity for you guys to engage with each other on some of this stuff. And we've heard great examples of how you guys are tackling this. We think this is really, this whole issue around risk stratification and risk management and care coordination is really the next step in the sort of evolution of the safety net engaging around value-based reimbursement models. It really kind of represents the trajectory of where we're having to build our capacity. And I think the more we can rely on each other, the better. So with that, Sam, I can advance for you if you want. I think I can advance. Hi, everyone. So I'll be very quick because we only have about 5 minutes left. So I think with this session, AJ will either send out or we'll send out afterwards our directions for the final project, which is not the next session, but our final session 6 for this VLC.
And in those directions, it'll actually probably look somewhat similar to the case study questions that we just went through in this session. But for the project, we kind of want to take you guys to take the concepts we've discussed and those types of questions that we've gone through in this session and apply them to your own situation. And so we've asked you to select a target patient population and stratification model, to analyze the quality and accessibility of your current data structures to support that model, and identify some possible intervention strategies to support your target population and to mirror sort of the different tiers that you're going to break out in your stratification model. And so for some of you, this might be a real-life exercise. You might be able to use current examples of current contracts you have in place or ones that you're considering or negotiating. And if not, if this isn't in your immediate future, we maybe think about what might make sense for you based on your particular patient demographics and your patient population and your practice and health center capabilities, what makes you, what your strengths are, things like that. And so for each of these different sections, we have a series of discussion questions there, so your group can go through them. So we said that. And then what we would ask you to do, it's really meant to it's not meant to be a really strenuous activity. It's not meant to take too much of your time. So we're going to send out a PowerPoint project template that outlines these questions following the directions. And we're going to ask you to complete just 5 to 7 slide PowerPoint, send it back to me. I'll compile all of them, and then you can come to that final session prepared to talk through your presentation. And we think about 10 minutes at the most is fine. And then we've asked, it's nice to have a chance to talk with each of you because you're a really great group. Amanda and Andy and I have really liked working with all of you. So we like to have a quick final project prep session where we talk through kind of what you're thinking, see if you have any questions. And I think most of you have signed up already, but if you haven't, you can follow this link to sign up. We'll have a quick 20 or 30 minute discussion. And tell us what you're thinking, and we can get you started to have your final projects finished. Any questions about that, or any thoughts that have come up as you considered this already? Okay. So I think AJ will send these materials out along with, we have a couple of homework questions up here going into next session that'll be part of the SurveyMonkey. So if you have any questions after the session, you can contact Amanda or myself. And thanks again for great participation today, and we're looking forward to talking with you in 2 weeks.